Hello to all. I welcome you all to the second ICCM Vodcast of this session 2025. And this second podcast, we have chosen a very important topic, difficult and prolonged weaning. So we all know that mechanical ventilation is and will remain one of the life-saving interventions in ICU. And weaning from mechanical ventilator is as important as its initiation. ISCCM, they had come up with their position statement in 2024 on weaning from mechanical ventilator, and they had come up with their 42 questions for which they have answered, and it's a brilliant work done by some stalwarts of ISCCM where they have given some recommendations and some good statements. So today it gives me immense pleasure to invite our experts to speak and to enlighten us on this topic on difficult weaning and prolonged ventilation. So firstly, I would like to invite Dr. Banambar sir. He is the HOD of the Department of Critical Care Medicine, SAM Ultimate Bhubaneswar. Sir needs no introduction. He is the pioneer of critical care medicine in our country. We all have been learning and are still learning from him. So welcome. I welcome you, sir. And thank you so much for giving us time in spite of your hectic and busy schedule. Thank you, sir. Next, I would like to invite a very dynamic lady, Dr. Chandana Sharma. She is the senior consultant in the Department of Critical Care Medicine and Internal Medicine from Health City Hospital, Guwahati. She is a dynamic lady. She have been working in and out in ICU day in, day out. She does her OPD and she is very much closely involved with the patient in ICU. So I have been working with her, so I have lots and lots to say about her. But in one word, that she is a very, very dedicated intensivist who is there with the patient day in, day out. So I welcome you, Chandaba, again.
Thank you, Reshu.
And
thank you so much.
thank you. So with me, we have Dr. Raymond Savio. He's a good friend of mine. And me and Dr. Raymond would be carrying you forward in this journey where we would be discussing about the difficult we face during weaning of patients. So, Dr. Raymond, today also I started when I had gone to my ICU. There was a case of pancreatitis, patient we intubated, ventilated, and then it's been 3 days since we are trying to wean him off. So I suppose it happens to you also, and how it goes forward.
See, thanks, Reshu, for choosing this particular topic because, when it is simple and when it is easy, we all ace through. Okay. And then quite often in many of our higher centers, especially, we'll end up stagnating. The patient improves, we do all those whims and fancies, and then at one stage, we'll end up stagnating. We have them with us for weeks, or sometimes even extremes. We even have them for beyond ICU care into the wards or into other facilities. So it's very nice of you to have chosen this topic for today's discussion: difficult and prolonged weaning. And I mean, more than you and me discussing, we have these two experts. So I think we'll kickstart a good discussion with Sir and Dr. Chandana. So,
Looking forward to
sir,
it.
maybe I have a leading question to you, sir. So, today's topic is about difficult and prolonged weaning. And, this kind of a classification, I'm afraid it's so old. I think it was in 2005 or something that during one of these international consensus conference that they came up with this. And in 20 years, so much has happened in diagnosing disorders, in the way we ventilate patients, in advanced modes or in diagnostic facilities, ultrasound application, and all that. It looks like this classification, simple, difficult, and prolonged, is more like a snapshot based. It doesn't tell us anything more. It doesn't guide us. Nowadays, we want it to be a little more intelligent. So, what is your take on this, sir? Do we still use this, or do you feel we should evolve? What is your opinion on this classification?
Thank you, Raymond. Thank you, Reshu.
I think it's a fantastic topic, and this certainly is a topic in evolution. It is not the last word has not been spoken on weaning. See, the first comprehensive international classification that came up was in 2005, right? 2005 classification is truly a comprehensive one. We cannot just ignore that. Still continues to be the best classification today. Any improvement that we do, it has got to be on that particular classification. So therefore, that is the baseline, and therefore we should not ignore it. And as I would like to believe that anything that is simple is easily assimilated and easily understood and easily remembered, right? So if you go into that classification, they had a number of patients. I think they had almost about more than 5,000 patients who were actually included in that. And they found that simple is within the 24 hours period. If you start weaning, the first trial that you give, spontaneous breathing trial, and then if you can really get out of the ventilator, extubate, that is the simple weaning, we call it. We still call it a simple weaning. If it is within second to the sixth day, they classified it as difficult weaning. And it has got to be at least 3 times spontaneous breathing trial. And if it is beyond 6 days, that is 7th day onwards, it is called difficult weaning. The problem with that classification is today that we realize that when they included so many patients, only 18% of patients were actually classified as simple, difficult, and prolonged weaning, right? Only 82% of patients could not be classified into that particular classification. So how is it that classification obviously will not be relevant for 82% of patients, and therefore this classification has an inherent genetic defect. Okay. So what do you do about that? Subsequently, when we started, there were studies. There was a Brazilian study in 2017, which was single center study, which actually took patients who were discharged from the hospital. So obviously, it's a retrospective study. 327 patients they studied in one particular university tertiary care hospital. And they found interesting results. When they found that they also had, classified according to the ICC international classification, and they found that 57% of patients were unable to be classified according to the 2005 classification. Why is it so? Because 57% of patients could not be out of the ventilator. If they could not be out of the ventilator, obviously they are not classified in the older classification. So therefore what they did was they added another dimension to this classification, and they said that there has got to be no weaning as the 4th grade, simple weaning, difficult weaning, and prolonged weaning beyond 7 days, and no weaning class. So no weaning had incidentally the maximum number of patients into it. What does it imply? It implies that when you have no weaning, what are the causes of no weaning? So the causes of no weaning could be because of the inherent disease itself, like for example, a neuromuscular blockade. Somebody who actually went into a very bad critical illness neuropathy, and somebody who had a neurological disease like a motor neuron disease, you would not be able to wean these patients on the ventilator. So therefore,
so was this labeled as weaning failure, sir?
This is weaning failure, obviously, because that's another dimension, Reshu, that you have added, very, very welcome addition. So that means that these are not only weaning failure, but these are also, to an extent, some of them are permanent weaning failure. So if they are permanent, a motor neuron disease, I had a patient, who lived for 6 years. He was going from bad to worse and he could not be weaned up. He was absolutely apneic at some stage, and obviously you can't win. So therefore, this particular classification will not be holding water in the present day context and understanding of our disease process, which has caused the patient to go on ventilator, and majority of them do not actually come into that particular thing, right? Neurological patients,
True.
patients multi-organ failure and they have gone into target organ failure. They are just living, right? Patients who have had spinal issues, who cannot actually breathe, who have a diaphragmatic paralysis, they can't actually
Mhm.
come out of the ventilator. So many such patients would actually have to be included in the classification of today.
Right, sir.
I completely agree with that, sir. So the most important take is, of course, yes, this is a very simplistic, classification, but this is so very important because simple things are easy to do. You can make it more and more complex by adding all those jargon, but then maybe bedside applicability becomes limited, but we have to have those in the back of our mind. And like sir pointed out, some of the nightmarish causes, motor neuron disease, we'll end up ventilating for life. And yeah, so I mean, talking about causes, I was just wondering, Dr. Chandana, so we have so many reasons why somebody's ventilatory requirements keep dragging. We have a very big list, but of course, most commonly we tend to cite cardiac or respiratory reasons.
True.
Uh, are there any ways you can? These are the two top causes, of course, but there are so many other. You may want to talk about them, touch upon them. But primarily, are there any ways that you can, clinically or quick bedside assessment try to differentiate, hey, this is cardiac or this is likely respiratory or some other also in case COPD, that is again one more difficult to wean situations. How would you differentiate them in the bedside?
Yeah, thank you, Dr. Raymond. A very pertinent question. As you've already rightly said, that a variety of factors can lead to weaning failure or difficult weaning, and respiratory causes among them tops the list. So, among the respiratory causes, we know that the most important causes would be an unresolved pneumonia, maybe an aspiration pneumonia, and in COPD patients, maybe because of dynamic hyperinflation, autopeep generation. And these are the different causes that may lead to weaning failure, especially for the as far as respiratory causes are concerned. Again, if we go to the cardiac causes, one of the most common causes that leads to weaning failure is a new onset heart failure. And again, acute coronary syndrome, then unstable arrhythmias, all these would lead to pulmonary edema and a resultant weaning failure. So, the most important, as in all cases, the most important way to differentiate is the clinical acumen. You need to have a very high index of suspicion. And apart from the clinical parameters, like which we usually, the bedside clinical parameters, ABG would help us to differentiate the respiratory indices. Again, a very important part, laboratory marker would be an NT-proBNP. If we do an NT-proBNP, we would perhaps pick up a lot of impending heart failure patients. And not to speak about echo and, bedside ultrasound. Now, bedside ultrasound has become a very important tool for the intensivist. And by doing a bedside ultrasonography, we can differentiate. By doing a lung ultrasound, we can check for the B lines and confirm about pulmonary edema. As also by doing an ultrasound, we can pick up diaphragmatic dysfunction, which is another very important cause of respiratory dysfunction in cases of weaning difficulty. So the basic tests, like I'm not going to details about the chest X-ray and the ECGs, but ultrasound, yes, it forms a very important tool for the
Yes.
intensivist to distinguish cardiac failure and a respiratory cause of
Respiratory.
breathing difficulty. Yeah.
Yeah, it's so true. We
So very
become
right. So very right.
so dependent on ultrasound we have become, isn't it?
Yeah.
And yeah, when it comes to a quick snapshot differentiation between these causes. Yeah, sorry, Reshu, you were telling something.
Yeah. But rightly, Chandaba have rightly said, Dr. Chandana, that clinical suspicion should always be there. We should be highly suspicion, like we should know our patient clinically and then we can look for the causes. Then only we can search the causes. And as she has said, ultrasound is now the most important tool in ICU, I would say, because we can see many things. So, sir, over to you. As we talk about so many numbers, as you were mentioning about the percentage of weaning failure, like during that 2005 study also, the recently we had a wean safe trial published in Lancet 2023. And it was a large observational cohort with multicentric approach. And the numbers they had reported were very scary, that only 65% patients ventilated for more than 2 days were successfully weaned. So, sir, any take on that, on the trial, sir? Because whether that trial will be of value today, as you had said at 2005, the definitions and the terminologies can be little bit difficult in present scenario. So, a little word on Bean Safe trial, sir, from you.
The data show that 65% of patients could be weaned off
Successfully.
within the 48 hours time,
Right,
right?
sir.
If you look at our experience over the years, and
Mhm.
if you plot the data, it will be actually that. It's nothing new. Okay. It is just that we do not have the data in our workplaces, and therefore we think that this is abysmally very, very low kind of a result or outcome, isn't it? Actually, it is like that. So 65%, I still would say it goes very well with our experience in various hospitals. I'm sure in your hospital, in my hospital, and everywhere else, it will be around that. This is quite plausible. And look at that, another 35% of patients, if you cannot win or you have a difficult winning situation, you have got to find out as to why this happens, right? So that gives you a tremendous scope and opportunity to find out the ways and means of understanding the winning failures, right? So winning failures, I think we need to understand that. When we practice, we often tend to be casual in initiating the winning process, and then we find once or twice or thrice we fail, and we take it very, very casually. But actually speaking, we need to really find out in that case that yes, why this particular patient we are unable to win, whether it is because of the original condition, whether it is because we have induced certain things like muscle relaxants, like corticosteroids, like our antibiotics. We are developing a process. Almost 80% of patients in some studies say that there is critical illness neuromyopathy. So therefore, if that is the kind of state of affairs that we create iatrogenically, then we need to understand that. And that is one of the main reasons, as we understand, as to why we do not get to win these patients so easily. So therefore, this is something which I think we should be repeatedly doing it. We should be very, very strict about spontaneous breathing trials. Give it for half an hour. Our indications of winning assessment as to why we were winning it. I think we need to understand that whether it is the proper thing to do. Often we win it so casually that actually this patient is not suitable for winning. So
Mm.
therefore, if we keep a data in our intensive care units, sometimes we do it, but routinely we don't do it. I'm sure, I think most of the ICUs would not be doing it. So if we do it, we will be able to find that our own data, that it may be even less. 65% is high, but it may be even less in our situations. if you have, no intensivists, not many intensivists, you have too many patients, more than 15, 20 or 25, you have to see, you end up in erring this, and you will be actually getting even lesser data than 65%. So therefore, I'm not surprised that WinShape actually brought it out as 65%, which is I would say very well, because such WinShape studies, which I was a part of also, I think you also may be a part of that. We understood how uh, casual we are in deciding to win, in taking our time. Today is a Saturday. We decide to win, but oh, Sunday is coming, so let's do it on Monday. The more time on a ventilator, I never do it. I even win a patient in the middle of the night, because if I am there around, right? I never go by that. 50 years on, I think I have never done it. I have wind off, contrary to what people do, even at 7 o'clock in the evening. It is my time. I will stay back there. I make sure that somebody will be there to look after the outcome of this winning. So if you do that, actually you will be getting less percentage of patients who are actually successful winning, or winning success you achieve. So that is it. Is that enough to answer your
Yeah,
question?
of course. And
Yes, sir.
I
Very
think we
much.
all we all had a smile on our face when Sir said weaning on Sunday and weaning at 7
Yes.
p.m.
I,
Some practical issues, pragmatic problems. Yeah, very true. In fact, one of the numbers in that study, again, if I remember right, it said almost 22% of people, there was a delay of more than 5 days from when the predictive tests were actually in favor of weaning.
Weaning.
So, although 22 looks alarming, I think if we take effective numbers in our own units or our own regions, it might even be more, including all the Sundays and 7 p.m., I think.
Yes.
So, thank you, sir. Thank you. So, yeah, so that puts the whole thing in a perspective, there are undue delays. There are difficulties in the way we define what is delay, how we move forward. So maybe we can ask Dr. Chandana now if you have any structured approach in your unit to handle these patients with difficult and prolonged weaning. Do you have SOPs? Do you have standard protocols? Can you please tell us an overview of what you would in your unit for a
Yeah.
typical case of prolonged weaning?
Prolonged weaning. Yeah, actually, when we deal with a patient who has a difficult weaning, meaning that he has failed an SBT, so after that we follow a structured weaning process, and that process starts from the day the patient fails the first SBT. When he fails the SBT for the next 24 hours, it is very important that we give enough time for the patient to recover, because he has failed an SBT. That means he was not ready for the weaning process. So most of the time it happens that we have not anticipated weaning failure. That is the reason that the patient has failed the SBT. So the important part of weaning, as a part of the weaning process, is that we need to determine the factors, which are the factors, and anticipate that this patient may have a weaning failure, and address these issues, each issue separately, so that the weaning process is very smooth. So as given indicated, like we always need to follow the steps of weaning. Like we need to check a pre-weaning screen. We need to see whether the patient is ready for weaning. Then we need to see for the parameters of weaning, indices of predictors of weaning, like the most excited the test which we all rush to before weaning is the RSBI. So the doing an RSBI, or seeing the respiratory indices, and there are so many predictors of weaning, as you can see. And at least if we can run through the test, and then we can say that this patient is ready to wean, and then go forward to an SBT. Now, once the patient has failed an SBT, the next 24 hours is very crucial, because in this next 24 hours, we need to put the patient into a kind of a stable and comfortable, respiratory support. We don't rush into another SBT in the same day. It is important that we give time to the patient, and it is this time where we need to focus on what are the causes that has led to weaning failure in this patient. And many a times it is either because of some nutritional deficiencies. It may be because of metabolic parameters, electrolyte imbalances, mainly phosphate, magnesium, hypokalemia. Most of the this electrolytemias we need to correct. If the patient has a low hemoglobin, we need to keep up the hemoglobin above 7. If the patient has dysglycemia, both hypo and hyperglycemia are crucial in this set of patients. So we need to correct these metabolic and electrolyte parameters. And then even if the patient has got, if we detect that the patient may be having some form of pulmonary edema, which has led to the weaning difficulty, we need to address this issue very aggressively. Either give them a diuretic or, something. And then if the patient had a ventilator dyssynchrony, maybe we can, with appropriate inspiratory flow, and we can also, change the trigger settings and make the patient comfortable. And then after 24 hours, maybe we can switch over to a SBT, which may not include a TP's trial, because the patient has failed an SBT. We may go into either a pressure support ventilation, or maybe we can try some other closed loop ventilations, which I think we'll be discussing very shortly. And once we start this spontaneous breathing trial, our idea would be to bring down on the ventilatory support, decrement the ventilatory support and prolong the periods of SBT to extend so that the patient is comfortable. And then we know that now the patient is ready for extubation. And before extubation, again, it is important, because the patient had a failed weaning or a prolonged weaning, we need to do a cuff lick test to see if there is any laryngeal edema. And if the patient if his cuff lick test is less than 110, then we know that the patient is not ready for an extubation. We go ahead to give a course of steroids or racemic epinephrine, and then after 24 hours we plan for an extubation. So this is the protocol which you usually follow, and most of the time these patients are helped by NIV. Post extubation, we need to put these patients on some kind of a NIV or a high flow nasal high flow oxygen, depending on the type of patient profile. A COPD patient would be more benefited, or an LV cardiac patient would be more benefited with a NIV following extubation. And make the post extubation period very comfortable for the patient. Monitor very closely, so that in the post extubation period the oxygenation parameters are dealt with, and we don't have another failure and have to go and re-intubate again. So this is the usual process that we follow in our ICU. And it's not very, it's like in all other cases, we do not, every size will not fit, it will not fit everyone. So every patient there, we have to give individual considerations. So in some patients it may be different. He may not fit into the particular weaning strategy which we follow for all patients. So every patient we have to tailor according to the individual needs. But most of the time, this is the strategy that is being followed in our ICU.
Absolutely. So thank you so
Dr.
much.
Chandana,
It's got to be seamless. It's got to be repeated. But the crux is that, like she rightly pointed out, you need to know why this patient is failing, or why we are not able to discontinue. Do meticulous SBTs. And again, Dr. Chandana insisted on not repeating SBTs more than once a day. That is so very important for all the trainees who are listening, because that 24 hours is a time that it takes for the diaphragm to recover back to its reasonable morphology. An exhausted diaphragm needs that 24 hours. So there's no point of doing an SBT in each shift or something like that. Don't do it like that. So know what you are fighting against, have a very stepwise approach, and you may have to just keep doing again and again with special nuances and adjustments. and don't give up. I think that summarizes what Dr.
Yes.
Chandana said. So, of course, are there any special or new predictive indices or newer weaning tools or something that can possibly help us in this set of special patients? Sir, do you use
Oh,
any new
uh,
scores or?
let me talk about the one that most of us use it on a day-to-day basis, RSBI that we talk about, and RSBI has a tremendous success rate, 97% it is said, but I think in my experience, you can almost rely on this 100%, except in situations where there is an not upper, I think anything below the vocal cords is a lower airway obstruction, right? So therefore, if there is a subglottic stenosis, if there is a glottic stenosis, then of course RSBI doesn't oblige you, right? Except that I think in most of the situations, almost in all situations, RSBI is a very, very good indicator. 104 is the magic number, but often we have seen patients are 30, 40, 50 also. I think they do very well. Okay, so that is without any question. I do not use any other score. I go RSBI, of course, and RSBI also you don't need to. In certain patients, you do not actually need RSBI. Post-surgical cases, a single spontaneous breathing test and is doing very well. Either the pressure support of 8 and PEEP of 5. And if somebody who had 18 respiration, even with this also 18 respiration, then I think you don't have to do actually RSBI. 18 means how much it is. 18 with 400 or 500, suppose tidal volume, it comes to 36, right? So 36 or 40 is a good enough number for you to rely completely and do it. But there are certain scores which are available, which I think one of these has been mentioned in our position statement also is the eye track score. Okay, that eye track, I am not sure how clinically it will be effective. You have 6 parameters: intubation, heart, of course it is intubation, heart rate more than 110. Then you have the renal dysfunction, you have bicarbonate more than less than 20.
2020.
Then you have
Creatinine.
creatinine more than 2.5. So some of these parameters, acidosis, of course, it is less than 7.25. You do not actually have to think of a weaning in such situations. A 7.25, who will be weaning it? So it is actually not practically possible to honor this particular eye track score in deciding whether you should actually do it. But the point is that it has got a good predictability. The predictability is that suppose something like this, 4 or more is there, score is more than 4, you can almost predict that these are the patients who are going to have prolonged
Along with.
winning. Or these are the
True,
patients,
sir.
not even difficult, are prolonged winning. So prediction of a winning failure perhaps is much better with this particular score. But taking out the endotracheal tube, this particular score is of no use. And there are the other parameters, like you have the tidal minute ventilation. Minute ventilation, our position statement says that it is 15 liters or less. But I don't agree with that, because it has got to, if it is more than 10 liters, you find out, you will keep them on pressure support ventilation. If more, it is 12 liters, you have a rate of about 20, you will see slowly that rate will go up and the patient gets exhausted. If the patient gets exhausted, you are finished. Absolutely. You can't think of a winning mode or winning strategy in the next maybe 48 hours unless you have taken care of this reason for hyperventilation. Could be residual sepsis, could be a little bit of temperature, could be, some neuromuscular issues, could be anything. So it is not going to be effective insofar as its applicability at the bedside is concerned. you have the vital capacity. How many of us actually do it? These are not something which we keep doing it on a day-to-day basis, because it requires the cooperation of the patient. Anybody who is actually sedated, who is also in a residual paralysis, what cooperation would you expect in this? I don't think that is actually applicable in our setting at all. Like you have PF ratio, which is more than 150. Even more than 150, I don't consider it as all right for winning. There are issues. Why should it be less than 200? So more than 150. And the position statement says that you have to have at least zero point 0.5 or 0.45 FiO2. I don't do it, because FiO2 point even 4 also, I will find that this winning failure is quite possible, right? I would like to wait till FiO2 comes down. Nowadays, I ventilate my patients with 0.21, 0.22, 0.23, right? We don't have to give so much of oxygen. You get a PaO2 of about 70, 75 is good enough. Even 65 is good enough, but that is it. So therefore, these are various parameters. There are many others, but I do not think that these parameters are of any practical importance at the bedside.
So rightly said, sir. I think you have pointed out few very important points like as RSBI or rapid shallow breathing index we do. We do it regularly. It's very easy to do. And bedside, it's a simple test. Bedside, it can be done. So it is the most commonly used indices. But sir, I wish, like many times, we always wish that Ray sir is there or Dr. Chandana is there in every ICU, in every shift, in every unit. But I know, sir, that sometimes it's not possible. So there are times where the ICU is left in the hands of maybe the junior residents or students. So there are few indices like these scores, which may be a little objective parameters for them to decide whether they can wean or not. And that is the way they can communicate with us. So iTrack score is one where it's used quite often, where they use it to predict whether the patient will be having a prolonged ventilation. There's another indices, sir. I don't know. Sometimes we have started using it, that the occlusion pressure at 100 milliseconds, that is P.01, which our ventilator, we have the Philips ventilator, which gives us that dynamic. It's basically used to see any neuromuscular weakness. If the patient is having neuromuscular weakness, so that helps. As you have said that when all the parameters looks okay, normal, the cause for which the patient was ventilated is corrected, patient FiO2 have come down, PEEP have come down. But if the patient is having some neuromuscular weakness, which is not so obvious that point of time, then that parameter, just P.0, 0.1, it helps. Again, as Dr. Chandana also mentioned, those ultrasound findings, especially the diaphragmatic study, seeing the contractility, seeing the contraction in the expiration and inspiration, that is also quite helpful for us also, and for maybe for teachings to the juniors also, it becomes sometimes really helpful. But nevertheless, RSBI holds good, and that is the test what we do day in, day out. Anything else, Dr. Raymond, you would like to add here?
See, and I mean, purely for completion's sake, there is no one test or one score that
Yes.
is going to be effective. We even talk about scores like crop index, ROX, although ROX was originally only in HFNC, we also apply it here.
The core
Basically,
index, I think, is one more one.
yeah, exactly. There are so many of them. I mean, not that any of them are strongly validated or anything, but regular monitoring tries to give us a trend of more like we become trajectory aware rather than having just single numbers or something. You have a roadmap of where we are heading to. You get to think whether you're doing the right thing. You can revisit your practices. So
True.
yeah, like you summarized most of it otherwise, I think.
Yes. So
Yeah.
now
So
coming from the indices,
Raymond, I just
tell me,
wanted to
sir.
crop
yes,
index
sir.
also is a good one, but crop index has a different utility, right?
I
So
agree,
crop
sir.
HFNC, you are putting it in, and whether HFNC is working or not working, how would you really sort of modulate the HFNC facility? So I think, and then where exactly you should think that no, HFNC is not working and go on to the next modality. So crop index is that, but not exactly for winning. Okay. It can be also because if crop index is doing better and better, then of course you can win the patient off the HFNC, no problems at all. So, but then the idea of all this is often quite versatile and different. Okay, that is it. But eventually, I don't know. I don't use crop index for winning at any
No,
time.
sir. Even it's just maybe more of theoretical, and because it's so complex, calculating the crop index or the core index, so it becomes really difficult using at the bedside. But for theoretical purpose, yes, there are few mentions of it. So we just thought maybe there are a lot of students who would be
Fine.
listening to it, so it might be useful for them, sir.
Okay.
Okay. So now besides this indices and the when we are seeing about the causes of the different for the weaning failure from respiratory, cardiac, metabolic, nutritional. So Dr. Chandana, would you throw some light on role of early mobilization and physiotherapy in
Yes,
which helps during weaning process or
absolutely.
early weaning?
Yes, this is one of the most important things which we usually, try. You see, neuromuscular weakness accounts for around 62% of the patients with weaning failure. And if you go to the causes of neuromuscular weakness, the ICU acquired weakness, which is so common, prolonged immobilization, and especially when a patient is on mechanical ventilatory support, the use of neuromuscular blockers and steroid, all of these, they causes some form of neuromuscular weakness in most of these patients. And there are limited data, although we do not have a huge literature in this subset of patients. The most of the data have shown that early mobilization and physiotherapy, it has got proven physical and functional benefits. And when we compare it with the others who do not get aggressive physiotherapy and mobilization, these patients, they show an increase in respiratory and muscular power, as well as in the extremity muscle strength, which is so very important for mobilization. And functional status of the patient improves after early mobilization. As also there is a psychological benefit when the patients are being mobilized. So we have seen that in the West, even when the patient is on mechanical ventilation, they are made to sit and mobilized, then all the physiotherapy and all are taken in the sitting position. So nowadays, even in our ICU, we are starting to do some of this mobilization from the very first day of mechanical ventilation. As soon as we stop the neuromuscular blockers and the patient is conscious and alert, we physiotherapy and mobility exercises. So this is very important because most of the studies have shown that there is a huge difference, because we can decrease the ventilator dependence, as well as increase the ventilator free days. And we do not have much data on whether it leads to a decreased mortality, but definitely the quality of life in the ICU becomes much easier, better.
Yeah, so
Right.
gone are the days where all patients on ventilators were eternally sedated or kept paralyzed. We start moving these patients on the ventilator. Of course, it's not an easy task, but as we keep doing it, we just get better at it. And it really helps us in the long run, avoid sedatives as well as preserves the muscular reserve, all that. Yes,
And
thank you so
patients
much.
get a psychological benefit as well,
Also, that's so much
Yeah,
Yeah.
important,
this is
isn't it?
so very
Prevention of
important.
delirium and so many
Yes.
things. Yeah. Yeah, that's very true. So how about see, nowadays we talk about a lot of application of artificial intelligence in these ventilators, closed loop systems, automated systems. Do they offer any big benefit? Do we have some sort of experience or evidence from that? Maybe I can ask Sir, any role of closed loop systems, automated systems, do they help us get out of this difficult situation?
Well, I think that's a very good question, Raymond. Uh, you know, we are talking of artificial intelligence today, but I think ventilators are the earliest equipment in the medical side, which actually incorporated the earliest AI facility. Like, for example, you have IMB. I have used it in 1979 for the first time in this country. Intermediate mandatory ventilation. That's also a kind of, AI,
Yeah.
right? And then you had, of course, nowadays many of us would like to be very comfortable with PRVC board. I see even a paralyzed patient also it's kept on PRVC. I have seen that. Okay. So PRVC is one of the most widely used AI facility in our ventilators, right? And there are, of course, many others which have come up now. So therefore, of the latest ones that I have used, both of them I have used is adaptive support ventilation and the NAVA. Okay. So, neurally assisted ventilation. So, therefore, this is both NAVA I have used about 7, 8 cases, but more or less I had given up at that stage, right? And adaptive support ventilation, you had Hamilton ventilator, if any of you are using it. I think it was about 15 years ago. I used it with the Hamilton ventilator, adaptive support ventilation. It used to be initially very, very good, right? You can use it for about 6 hours, 8 hours, and you feel that you have got the solution to the patient not getting settled on the ventilator. So adaptive support would do, but it did not translate into reducing the days of ventilation and the weaning. It did not improve the days of weaning, the adaptive support. Insofar as NAVA is concerned, NAVA I did it, I think for chronic obstructive pulmonary disease, it became out of 3 or 4 cases, I think I got good results. In at least 50% of patients, I reduced the number of days on the ventilator. I did that, but this particular two of them, out of these two, one patient actually again needed ventilation and she died at that stage, almost about a time I was with Apollo, I think must be about 12, 13 years ago. She died. So I cannot say that it is actually very good. You have to be extremely careful in these fancy modes to be all the time monitoring. But ICU being what they are in our scenario, you will not find somebody watching those modes, how they are performing, and a critical analysis and telling you that, sir, this is what has happened. And you can't be sitting there all the time. But I suppose if you utilize this with proper monitoring, they may be doing some good. But I'm still today not sure that these automated modes are actually doing any good insofar as weaning is concerned.
I completely agree, sir. If it was the case, by now we all would have jumped onto the wagon and we would have switched over to just that as the mode of weaning. Of course, there are many things. Each one of these, maybe IntelliVent or the ASV or the NAVA, each one of them have one interesting thing. Probably if there is something that we can all put them together, might be a good thought process. But individually, each one of those automated modes are definitely not useful at this time point, I suppose. And therefore, so I think we've walked our way starting from definitions all the way to what next sort of a situation. And we land up having a good chunk of patients who stay with us, although not big numbers. Definitely in our everyday practice, we land up with a proportion of patients who stay with us for a long time on the ventilator. We at some time point more to tracheostomy. Of course, timing of tracheostomy maybe we will not discuss today for good interest of time. And then the patient stays on BiPAP or whatever. Basically, they transition on to what we call as long-term acute care or chronic critical illness or something like that. So both of you can just give me your experiences about how you handle these patients with long-term acute care. Do you transfer them to any special centers, or how often do you use home ventilation? How do you monitor these patients if you send them home with a tracheostomy and say a BiPAP? So this will be a very important discussion. We would like to hear from both, because a lot of us, this is a gray area. A lot of us do so much of this, and we don't have clear guidelines or indications as to how to proceed. Sir, you can.
Yeah, again, this is a fantastic question, Raymond. Long-term ventilation, home ventilation in a special acute care area, we all have done it, okay? And we are still continuing to do it. But let me tell you, the initial apprehension that patients will not be doing well has almost gone. Okay, we had a patient for nearly 7 years. I think he was a motor neuron disease. He continued to be on home ventilation, and the families actually they are much more concerned than any of us healthcare givers. We are concerned, but they are much more concerned. So therefore, they convert that room into an acute care room, which is nothing less than an intensive care unit, and the care wise even better than the intensive care unit. The two eyes are all the time watching. The family is very much in and out of that particular room. And this particular patient, whom I left him for about 7 years, did very well until few times, of course, he has come to the ICU for certain initial, particularly the urinary tract infection and sepsis. But the last time that he came to us with UTI sepsis was a very bad multi-drug resistant UTI sepsis, did not improve and died in my ICU. When he died in my ICU, the family had the grouch. I had been going to their house without charging any fees. But then when they found that the patient died in our ICU, he said, "Sir, in our house, there was infection which we were able to treat. In the hospital, you have given an infection which you could not treat, and therefore we are very, very unhappy." Look at that. I think they have a point in saying so, and I accepted the defeat in this particular case. This is what we do, because in my ICU, the infection rate, the UTI rate is 1.5, 1.6 per thousand catheter days. But for this particular patient, it is, 100% I am ineffective in this. So therefore, we have these issues, but outside, they do very well. And there are, of course, rehab centers today available. Rehab centers, I do not think in my city, rehab centers are no good, because when they go to the rehab center, sure enough, after about 15, 20 days, they come back with us with a very bad resistant infection, particularly urinary tract infection or a pneumonia, which is multi-drug resistant. So, but there are rehab centers, good rehab centers, from where patients do not come back, they're still alive. I am attached to one of those centers. I think this center does exceedingly well. I'm quite happy that the patient could be shifted to that particular unit. Of course, with a BiPAP ventilator or without a BiPAP ventilator, and they do very well. I'm attached to that particular organization, honorary attachment, of course, and I know that they do very well in such units, acute care units.
Dr. Chandana, would you like to throw some
Actually,
light?
yes,
Also?
I mean, there is nothing much to add on to what Banambar sir has already spoken, but I think it is a much needed strategy today to, level the largely unmet needs of a fast aging population of our country, because we can see that now even there are a small subset of patients in the ICU. They cannot be liberated from the ventilator up to maybe 21 days, which we call as prolonged mechanical ventilation. And there are another subset of patients who, because of neurovascular disability or because of some stroke or brain surgeries, they do not they are on tracheostomy for a long time. And it is no good keeping these patients in an ICU where there is a mixed population of patients, where there are patients harboring life-threatening infections, because these are immunocompromised patients and they can catch up any, as sir has rightly pointed out, an hospital-acquired infection. So I think it is time that because to recommend such a center is very difficult. It's very for as physicians, we cannot just tell the patient that you take him to a rehab center where we do not know what is the quality of that rehab center, especially in a resource limited country like ours, where there is no quality assurance of the rehab centers that we have seen. So it is very important that we we should try and convince the authorities, as well as on the private setup also. We need to start some centers where post acute care rehabilitation can be taken care of in a much better way than the current circumstances. Because in the West, the long-term acute care setups are doing extremely well, the hospices and all. And it is also important that these long-term acute centers, they have a good collaboration with the primary hospital, so that at the time of crisis, we are there to help. And a multidisciplinary team needs to take care of these patients. Actually, it's not just the nurses and the therapists, but we need a good respiratory therapist, a physiotherapist, doctors, nurses. A multidisciplinary team can actually help in to these patients by decreasing the rate of infections and long-term care. Because we cannot do away with them. We have to meet this situation, and we need to form a strategy as to how to take care of this patient. Most of the time, because of financial constraints, these patients, they have to be sent to a rehab center where quality, we do not know the quality, we do not know how they are being treated there. So it is high time that we as a society take up this responsibility. And ISCCM has come up with a position in their position statement. They have suggested that patients who have weaning failure, they can be considered for transfer to a center like this, a center where we can take care of these patients with prolonged weaning as an acute post-acute care rehabilitation.
I think there's a very important point which you have come up, Dr. Chandana. Like, there is this need of this rehab centers for the long-term acute care, which should be attached to the primary hospital, so that the quality can be maintained.
Sure.
I think that is a very valid and point which you have come up with, and maybe this can be a scope of discussion in the future as well when we are discussing more of such scenarios. So I think we have almost come to an end of our session, which was, I think, very enlightening, very informative. And so I would just request from my two esteemed learned speakers, would you just like to give your closing statement to the topic? Ray, sir.
Yeah, sure. My message to all our colleagues will be that be very, very committed to these patients. Never give it as an instruction and walk away. Okay. Make sure that somebody who should be actually working with you and you know his credentials, he would be standing by the patient all throughout. I'm not saying that you should be sitting, taking a chair and sitting there. But even a nurse also doesn't sit in our scenarios. I don't like that. I have tried my level best. In 51 years, I have not been able to keep a nurse glued to that particular patient, even if I have given 1:1 nurse for a ventilated patient. they would find out an alibi to go to the central station for some reason or the other and chit chat. This is what I have found. But I am only saying to a doctor and to the nurses that even if you go, keep your monitoring alarms absolutely in perfect condition, 15% more, 15% less. But whenever there is a alarm, please come and attend to these patients. But our ICUs in India, I have found, they are noisy ICUs. Okay. Monitors will be on and on and on. They are generally not bothered. And when there is a true catastrophic situation, also they will not be bothered. Right. And this is what I have found. So if you can actually make your ICUs noiseless by setting your monitoring standards, but whenever there is a alarm on, please immediately go and attend. Try and see if you could actually be glued to the patient all the time. And of course, the doctors, wherever you go, but keep your eyes and ears to this particular patient who needs your attention anytime and come back quickly to attend on him. Then I think we will do a very good job. More so for weaning. And weaning, do not start weaning and walk away. When you are weaning, if half an hour you have given a spontaneous breathing trial, be around that patient all this half an hour today, right? And after half an hour, if you think that he has not stood the weaning, connect to the previous mode and then you go. But never walk away during those half an hour or 30 minutes time. I think commitment
Very
level
important.
and your sincerity of purpose has got to be there. Then only we can do good to our patients.
Very important point, sir. Thank you. Dr. Chandana, your closing remark.
Yeah, nothing much to say. Actually, we had a very good discussion, and it's just like weaning, as we said, most of the time it is not very difficult. Most of the time it's a very rapid and smooth process. But in those patients where it becomes prolonged or in which it becomes difficult, we need to stick to a weaning process. That is very important. And these are the patients where we need to anticipate early and address the issues which might be of concern, so that we can go through the weaning process very smoothly. And if we follow a protocol driven weaning process in most of the ICUs, the outcomes are really good. And so we need to reiterate that we have to focus on the weaning process. And as we've already discussed, that I think most of it we can deal with very well, apart from the prolonged and difficult weaning where we need to be more cautious.
Thank you.
Yeah.
Dr. Raymond, anything? And then we can
It was an
sum up.
absolutely thrilling discussion with our experts, and I think we walked all our way till some very important and evolving concepts. And the bottom line, which all of us seem to be talking about or stressing about, is a dedicated and a systematic approach. Most of the times, we are likely to be successful if there is a dedicated approach. And of course, there are a lot of new tools and techniques that are coming in. It is important, it is very imperative that we know them. Even if it is not useful, we need to know to be able to really apply the larger understanding of this science, which is very important when handling these patients, because it's not just the science that we handle. Quite often we handle emotions, financial constraints. So a larger perspective and a dedicated approach is very important. So, with that, Reshu, maybe we should be concluding this session.
Yes. Okay.
I'm really thankful to ISCCM and the leadership at ISCCM who have made these sort of series on podcasts and so many other online events happening. And ISCCM is all abuzz with so much interesting programs. Thanks a lot to our esteemed faculty, Dr. Banambar sir and Dr. Chandana. Thanks a lot, Reshu, for making this podcast very interesting. It's really nice that we could catch up today. And to everyone else, so nice that you've been with us, you've joined us. And see you very soon in our next month's Friday release. So thank you so much.
Thank you.